Next, we'll hear opponent testimony from Spencer Cahoon. Welcome and thank you for your patience.
Of course. You guys keep busy. Thank you, Chairman Manning, Vice Chair McCauley, Ranking Member Thomas, and members of the Senate Judiciary Committee for taking the time to consider this opposition testimony to SB 216. My name is Spencer Cahoon. I'm an Ohio resident and a prior social worker with experience working with families, and children, and people with substance abuse disorders. In preparing for this testimony, I also reached out to a social work colleague of mine who has spent over a decade working with Franklin County Children's Services at both the case management and supervisory levels, addressing exactly the sort of cases contemplated in this bill. Dylan's death was a tragedy. No child should have to suffer such a fate. This bill, however, risks compounding that tragedy by overwhelming the limited resources of the overburdened children's services system, misunderstanding substance use disorders and treatment, disparately impacting poor communities and communities of color, and creating unnecessary trauma for children and families while undermining Ohio's family unification-focused approach. Other targeted changes would better address the concerns raised by Dylan's death. Specifically, requiring pre-placement monitored drug testing for substance-exposed infants already removed from the home is something pointed out both by the proponents and by myself as well. Secondly, authorizing and empowering PCSAs to engage with pregnant women for proactive supportive services and treatment prior to delivery, something that many, if not all of them, are currently prohibited from doing. Looking at the system resource impact, Ohio's children's services system currently struggles to recruit and train enough foster placements. Many substance-exposed infants are not currently placed into foster care systems. The decision to place a substance-exposed infant into foster care is based on multiple factors, including the severity of the substance use disorder, the additional supports available and utilized by the parent, and the parent's previously demonstrated level of functioning. Substance use disorders are differentiated by the DSM-5 into 3 levels of severity: mild, moderate, and severe. Parent needs and infant risk can vary significantly between a new mother with a mild marijuana use disorder and one with a severe heroin or oxycodone use disorder. Current practice allows for supportive services in the home or community, voluntary safety plans for new mothers who recognize their disorder and seek treatment, and, in cases of higher risk, removal of the child. Mandatory removal for any substance-exposed infant under this bill would remove significantly more children to foster care. Local PCSAs lack the families for placement or the amount of funding necessary to address the mandate. Perhaps more importantly, it will be a significant increase in foster placements for children least in need of that high level of service. Looking at substance use disorders generally, substance use disorders still remain a pervasive problem in our society. We have many treatment programs and resources to help people overcome them, and relapse is a normal part of the recovery process. The Center for Disease Control has noted that relapse is not a sign of failure. It is best understood as a sign that more treatment or a different method of treatment is needed. This bill, by requiring ongoing negative drug tests, unintentionally stigmatizes relapse and prohibits timely reunification. Because of the harsh consequences of relapse under this bill, lack of reunification, it strongly incentivizes a relapsing parent to lie about the relapse or attempt to trick the system. To ensure child safety, we need a system where parents undergoing treatment can safely report a relapse so that treatment can be adjusted. That can only happen in a system where relapse is not an automatic disqualifier to reunification. Reunification should be based on comprehensive, evidence-based assessments of the parent and overall home instead of a one-size-fits-all rule. There's also the risk of disproportionate impact. Based on my colleagues' experience speaking with hospital staff at various locations, testing for drugs of abuse is not routinely done at delivery. It is performed on a discretionary basis when the doctor or nurse has a suspicion or concern. That informal process means that doctors' and nurses' biases factor into the testing decision, which will result both in poor mothers and mothers from communities of color being tested at higher rates. We already know that doctors and medical students treat Black patients differently regarding pain, and that racial disparities continue in pregnancy-related mortality. The CDC has identified bias in healthcare as an important step forward, and addressing that bias, I should say. This bill's requirement to remove a substance-exposed infant upon reporting takes away the discretion of local PCSAs to make case-specific determinations that can ameliorate that healthcare testing bias. So looking at targeted alternatives, because there certainly has been interest in this committee in seeing what can be done proactively. The type of tragedy that claimed Dylan's life can be averted by less severe changes, such as requiring pre-placement monitored drug testing in cases regarding substance-exposed infants removed from the home. Similarly, our PCSAs are unable to provide services to expecting mothers who do not already have children in the home. Expanding their service provision to expecting mothers would allow our PCSAs to act as a resource to get pregnant women treatment and supportive resources early on in their pregnancy to help prevent the need for later removal. Early treatment, support, and better pre-placement testing can help prevent tragedies like Dylan's death and support the welfare of all of our children. In addition to my written comments based on the questions that have been raised by the committee, it has been brought up the concern of PCSA funding and turnover. And I can tell you that in Franklin County, caseworker pay is slightly above working at White Castle and slightly below warehouse work. And turnover is endemic because of that. And this is for positions that require a 4-year degree and people who carry the amount of educational debt that routinely comes with such education. Changing the amount of funding that goes into that, payoffs for people who have educational debt after a certain amount of service, public interest loan forgiveness, are other methods that can be used to create more senior staff that have a better understanding of the system, and we don't run into these turnover issues on and on, making it more difficult for families trying to recover. This bill in its current form creates unnecessary trauma for families and is a departure from Ohio's family unification-focused approach. Please consider a change of some sort to the targeted alternatives to address the needs underlying this bill, while still acting in keeping with Ohio's family unification-focused approach. Thank you for your time. I'm happy to answer any questions.
Thank you so much for your testimony. Are there any questions from the committee? Seeing none, thank you once again.